Hello, I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma Health Sciences Center, and I'm very pleased to be part of this Cambridge Health Tech Digital Pathology and AI Summit. I appreciate your interest in joining me for I hope, a challenging and intriguing discussion of how these two entities can impact medicine in the developing world. So, my goal today is to perhaps explain and explore how this interface of technological change, such as digital pathology and AI, coupled with the demography of the world and maybe even the pandemic, may interact to create an opportunity that is truly singular and potentially life-changing for many in the world. And hopefully that discussion will motivate you to join me in a journey to save the world. I have nothing to disclose here other than that I know there's a lot of work ahead in this process. I appreciate the opportunity to talk to you about this, but let's begin with a very big number, 21.7 million. That's almost unfathomable, but that's the estimated number of new cancer cases anticipated in 2030. Now that's just 1 year. That's an increase of over 40% over the actual measured increase, measured incidence in 2015. So I think it's based fairly reliably on existing demographics and trends. But why? This is an enormous number. And more importantly, where are these people and who's going to care for them? Well, that raises this question, I think, which is how many of these 21 plus million people will get an accurate diagnosis that will allow them to obtain appropriate treatment or get a diagnosis at a time when that treatment can be effective. If this isn't a question that keeps you up at night, I can understand that. But if you have any degree of foresight, and certainly if you have any connections with people in the developing world, developing countries, this is likely to be a number that will impact you or those whom you know. The answer to that question, of course, is not enough, because not all of them will have that opportunity. Indeed, perhaps a very large number of them will not. If we look at kind of what's been happening behind this, why this has been going on, well, there are a number of trends that have been happening worldwide that help to explain this. One is that many of the communicable diseases, respiratory infections, HIV, TB, malaria, these have been stable or falling for the last several decades. And of course, this has particularly affected the developing world. On the other hand, as lifespans have increased, as population has increased, the non-communicable diseases, stroke, ischemic heart disease, and cancer, have been correspondingly increasing across the world. Now, if this were evenly distributed or distributed according to where there was adequate health care, that would be one thing. But of course, these are not evenly distributed. And in fact, a tremendous amount of this burden is going to fall on the developing world. If, for example, we look at a continent like Africa, the total population in Africa right now is about 1.4 billion. And to serve that population, there are less than 2,000 pathologists. In other words, that's an enormous population to be served by a minuscule population of potential diagnostic pathologists. And their cancer cases anticipated in 2030 is going to be roughly 2.6 million, which even if this number were to double, would be an extraordinarily difficult burden to manage. There is a need for a tremendously much larger number of people, or tremendously improved manners of obtaining and getting a diagnosis for these people. Similarly, if we look at Southeast Asia, current number of pathologists slightly better, 1,600, maybe more, a population of 676 million. and with a smaller cancer burden overall, but still a very significant number. And we can look at other developing areas of the world as well and see similar stories unfolding. Now, if these numbers don't scare you, imagine how daunting it would be to be one of these 1,500 pathologists and be looking at that wave of cancer specimens, cancer cases that are about to engulf your country. It would be very, very discouraging. So how does this impact with disruptive innovation? Well, just to review, disruptive innovation is a theory that was developed by Clayton Christensen beginning in the early 90s when he left business and management to pursue a doctoral degree in business. The outcome of that doctoral work was one of the groundbreaking theories of modern economics and modern business, titled The Innovator's Dilemma: When New Technologies Cause Great Firms to Fail. Now, if this had no application to healthcare or to the developing world, I wouldn't be bringing this up. So let's just look at how it might apply. With disruptive innovation, the existing entrants in the market, the providers of steel, of computers, of healthcare, they're following a pattern of innovation and service that is filling the needs of their population that they serve, their customers, and aiming to improve on that, to do a better job and to innovate upward to serve those people better. What they're not doing, however, is innovating for the people who are not seen as their customers, who are not able to afford their products, who are not engaging with them economically, either due to location or economics or other factors. But what happens oftentimes is that these innovations of such companies tend to overshoot the actual customer needs. And new entrants come in with a new technology or a new service or a new model that begins to meet some of the needs of those people who are not being served. And it does so usually at a lower price point or a more accessible manner that therefore allows them to begin to attract customers who are not the ones who are using this product up here, but would have otherwise been underserved or not served at all. As this entrant into the market begins to innovate, their products improve, they begin to approach the point where they can serve the customer needs of a larger quantity of people, and potentially that disrupts this provider and their customers look elsewhere. So the ridership of Uber goes up, but the yellow cab goes down, et cetera, et cetera. Well, does this apply to healthcare? Well, yes, I think it does. So these existing providers, the Mayo Clinics, the Roche Laboratories, the various other conventional providers in a market that may seem as very stable, are not concerned about the non-consumers in another environment. They're not concerned about the non-consumers even in their own market sometimes, despite what they may say. And so although they may give lip service to providing care for these individuals, they haven't structured their business model to do so. And this opens the opportunity for potential disruptors, either technologically, organizationally, or otherwise, to come in to begin to serve and compete against them with these people who are non-consumers, essentially, creating thus a new market for their new services that may not be as good, but fill a need that these people were not having met at all. So how does this apply to our scenario? Well, just as I've said, disruptive innovations often compete against non-consumption. They're competing against nothing. This is better than nothing. They provide products or services that are good enough to those who would otherwise have no access or no ability to use a product or service. And in fact, one of the things that we learn from this is that these unserved markets often succeed best when they can pull in resources rather than have them thrust upon them, if you will. In other words, the innovators within the country who pull in the infrastructure to provide clinical testing do much better than the IMF donated sequencing machine that serves only as a trophy for the laboratory to display to tourists through its environs. The other principle that is important to remember here is that established providers will ignore unserved markets and focus on established customers and markets. They are going to put their best efforts to serve those who provide their living. They are not going to go investing in new markets that are questionable or unserved. So as many as 10 million new cancer patients in 2030 could ultimately be classified as non-consumers of diagnostic therapeutic processes. This is a huge number. That's almost half of that 21 million cases. And although it may seem like an ethical contradiction here, for those people for whom none would have been their option, something that is better than that offers them more hope and more opportunity than they would have otherwise. But the existing vendors and lenders and healthcare organizations that are oriented around a return on investment are generally going to ignore these patients. So what else should we be thinking about? Well, as we look at a market, as we look at a country or a setting, existing manufacturers and providers will ask, well, what do we like to serve here? Are there people who can purchase our products? Are there those who can dispense or diagnose, who can distinguish between HER2 positive tumors and HER2 negative tumors? Well, if so, well, then they may choose to enter. But by and large, many existing high standard providers will have great difficulty endorsing anything that is just good enough or better than nothing. And there are truly moral and ethical considerations that need to be addressed. But in seeking to do no harm, doing some good is better than doing the harm of doing nothing. Along with this, as we think about developing the capabilities here, we have to recognize that brain drain is a very significant problem. And that as new people are trained to provide services at a higher level or with improved quality, the temptation to be taken away to other markets where their services are more richly rewarded is going to be very difficult to resist. So, and then lastly, who's going to begin to bring these new innovations diagnostically and so forth to this half of the world's population? I think you've already recognized that it's probably not the existing providers. So this is where digital pathology as an innovator, artificial intelligence as an innovator, has a very significant moral and ethical choice to make. Can we truly provide good enough care to make a difference in these settings? Well, let's just look here at maybe a model for what goes on in a healthcare system, and whether this is in a developed country or an undeveloped country. There's this general population that moves and upon experiencing symptoms based on their educational background and so forth, comes to seek care. That may require referral to a hospital or a healthcare system or a diagnostic center, which is supplied by various reagents, equipment, and so forth, and by personnel to perform that testing and training and provide the therapeutics to hopefully lead to healthy outcomes. So this is a healthy model. But where does it go wrong? Well, in the developing world, we see lots of reasons why this model fails. There may be low level of education, cultural barriers, or other things that prevent people from getting care. There may be distances or costs involved, travel and so forth, that prevent them to access clinicians or make consultations. The supply chain may be non-existent or broken or corrupt. The facilities may be inadequate. There may be improper management and economic system to support and sustain those. The training may be poor, and those who do get training may leave, leaving us with insufficient manpower situation. And we may mistake things in diagnosis, leading to improper utilization of resources and bad outcomes. There are lots of reasons here. This is a very complex system, and I'm not proposing that we solve it in 20 minutes. But I do think that digital pathology and artificial intelligence have great impact, a potential great impact on this system, particularly in these two realms. In the training model, and training pathologists specifically, and also in the diagnostic quality that can lead to increased healthy outcomes, and therefore potentially impact a sustainable economic system. Well, how might that happen? Well, one of the things that has to happen is this enabling deployment of digital pathology. But right now, we're dealing not just with vaccine hesitancy, we're dealing with digital pathology hesitancy. We have digital pathology systems that, to the outward observers, appear to carry a very high price tag with an uncertain or unknown rate of return. And despite the efforts to validate the return on investment, this has not been fully demonstrated in the developing world where these needs are so great. Moreover, and this is very significant, that the costs and benefits of adoption of digital pathology or AI are very unevenly distributed. In other words, those who reap the benefits may have nothing to do with the investment or paying the price. And those who are paying the price may get only marginal or barely defraying their cost kind of returns. That's not an ideal system. Along with this, public health events and trends in distant locations appear to have little impact on us. And so we're not motivated to make a difference or to change things until they do. And if there's one lesson from the pandemic, it is that the things that go on in China, the things that go on in another country matter immensely to us. And we may say that the cancer incidence in Rwanda is trivial, is insignificant compared to what we're dealing with. That's not going to be the case. There will undoubtedly be ripple effects throughout the world to that wave of non-communicable diseases. So one of the things that has come from this pandemic, of course, is that we've seen that telehealth, telecommuting, these are very viable options, that remote education can be provided in a very meaningful and effective manner, despite the social distancing and separation that we've had to endure due to this pandemic. So there is a path out of this that is very, very significant. Just to be more specific, there are several potential gains from digital pathology. One is that we can train more practitioners remotely, and we can at the same time raise the quality of those who are practicing in remote locations. We can increase the effectiveness and utilization of specialists, whether that's a neuropathologist or a transplant pathologist or someone else who's relatively underutilized. By using digital technology in this manner, we can maximize or enhance their effectiveness. And that likewise increases access for patients in remote locations who would otherwise have no access to specialized care. And finally, this enables the manufacturers, the drug makers and so forth to enroll more patients in clinical trials, because these sorts of tools solve some of the distance and access problems that otherwise would keep those patients out of such trials. Now, with regard to the education parameter, this has spawned what I've termed the residency in the cloud idea. And basically this is that we can provide low or no cost education and training in a meaningful way that can prepare competent and adequately trained pathologists for a vast amount of the work that is to be done by pathologists by distance learning and mentoring. What's needed to be able to accomplish this? Well, we have to have access. People have to have computers, laptops, phones, or whatever that allow them access to the internet. And that content on the internet needs to be low or no cost. The content that is provided needs to be curated, relatively standardized, but also customizable and directed towards learners who may have different circumstances and needs. We also need to provide mentoring for these remote learners, the kind of personal mentoring that will be able to assess competency as well as correct deficiencies in a timely way. And then these have to be effective in achieving competency to practice that was therefore able to be credentialed over time. That's a tall bill of things to satisfy, but it is not unreachable. So coming back to where we started, what does this young fellow growing up in a developing country have in his future? Well, the future can indeed be very bright for such a person. If, and this is a big if we begin now to prepare the diagnosticians and the practitioners who can assuage the challenges of cancer and other non-communicable diseases that lie ahead in his life, in the life of his parents, grandparents, and others that he will be related to. So what? What are we going to do? Well, we can't expect to solve these problems today with the very systems that has created them. We need to take a new approach. We're proposing to form an alliance to promote equitable access to virtual digital pathology education that will lead to credentialable activity ultimately. Maybe not immediately, but ultimately. To do that, we need volunteers, we need organizational support, we need leaders with passion and innovation who are willing to look for solutions to this problem of access to care for the millions of people, billions of people who are today underserved. To quote a famous gentleman, we have the technology. We can do this. We have shown that we can do this. And so the question then for you, our listeners, is will you provide the will, the leadership, the perseverance, the camaraderie in this journey? I do hope so. And I hope that we can connect. So please reach out to me in various ways and share your questions. I look forward to your questions and answers. And thank you very much for attending this session.